Let us start after the inaugural session. Let us start with the session on ventricular tachycardia updates. We'll start with the Professor Ajit Kumar sir. How to approach a case of Brugada pattern in the ECG, current status of challenge test and EP study.
So good morning, everybody. At the outset, I would like to thank KHRS for having given me this opportunity. So I'll be basically talking on the approach to Brugada syndrome. So I'll be discussing on what is Brugada, the Brugada ECGs, the concepts, diagnosis, the flecainide challenge test, prognosis, EP, role of VT, inducibility, and the role of VT inducibility and the role of ICD. So it'll be a basic talk. So what is Brugada syndrome? It is a complex clinical syndrome with the pathognomonic ECG phenotype, as most of you know. This phenotype is characterized by the risk of VF and sudden cardiac death in a no structural heart disease situation. The characteristic ECG, as all of you know, is right bundle branch block with ST elevation and T inversion. The genetic base, one should understand that it is incompletely understood and is likely to be heterogeneous. Now, this is the typical Brugada ECG. It is the type, we have the type 1 and type 2 and 3 patterns. The type 1 pattern consists of right bundle branch block with code ST segment elevation and T inversion, while the 2 and 3 patterns consist of right bundle branch block with saddleback ST segment configuration with variable degrees of ST segment elevation. So this is a typical Brugada ECG. If you look at V1 and V2, you can find there is a right bundle branch block with ST elevation. And if you look at it a little more carefully, you can see that there is a left axis deviation or a leftward deviation, which also is a feature or there are certain other EKG features which we will deal with. So let us now look at some specific aspects of this Brugada ECG. Now, if you look at the J wave amplitude, it is the J point is elevated in all type 1, type 2, type 3 patterns. The T wave is negative in type 1. It is in type 2, it is biphasic or positive, and type 3, it is positive. While the ST configuration in V1 is code type, saddleback, and type 2 and 3. Now, most of people, when they come for patients, when they come to you, either you tend to ask them for high lead ECG, and sometimes it does not happen. But these are the typical high lead ECG positions: lead, second and third intercostal space, right-sided leads. And as you can see in the usual ECG, it has not picked up this type 1 Brugada pattern, while you can see clearly the type 1 Brugada pattern is picked up in the high intercostal space ECG. And why? That is because it tends to pick up the RVOT from second and third interspace. Now, what are the other electrocardiographic features that you should look up to when you are looking at a Brugada ECG? You should look for left axis deviation, first degree heart block, presence of atrial fibrillation or flutter, fragmented QRS, STT alternance, VPC of left bundle branch morphology, and if you have PR interval of more than 210 milliseconds, a QRS of more than 140 milliseconds, and if you do an ERP of less than 200 milliseconds and HV of 60 milliseconds, and certain high-risk features, the AVR comes in almost in every part of ECG nowadays. So the AVR sign is a dominant R in AVR, early repolarization syndromes, S in lead 1, and QRS fragmentation V1, which are high-risk ECG features. These features you should look up. Now, what are the genes implicated in Brugada syndrome? The typical gene implicated is the loss of function in SCN5A gene that encodes for the alpha subunit of the Na 1.5 sodium channel, but it's positive only 20% of patients. But look at the amount of other genes and channels which are affected in Brugada syndrome. So Brugada syndrome is not just a genetic mutation of one single gene, as you can see. So this is an interesting and important slide for people who are interested in Brugada to look at. Now, is Brugada syndrome a multisystemic disorder? SCN5A is expressed throughout the entire body. And mind you, it is an oligogenic syndrome that can result from the effect of multiple gene variants. Interestingly, SCN5A is expressed throughout the entire body, the largest protein expression being in plasma, heart, and pancreatic juice. SCN4A gene encodes for Na1.4, its mutations are related to myasthenic syndromes, non-dystrophic myotonis. So you can have neurological problems associated or related. Overlaps with ARVC, hypertrophic cardiomyopathy, it will flutter, Lenegres, and even WPWs. So the Brugada ECG is only a surrogate marker. Is essentially is a multi-omic syndrome that involves genetics, epigenomics, transcriptomics, proteomics. This is only to prod you and think about it in a little different way as well. So let us look at the basis of J-point elevation. These are based on coronary wedge preparation studies. Ventricular epicardium expresses a transient outward current ITO in high levels, resulting in an AP notch, while the ventricular endocardium expresses ITO at low levels and therefore does not have this notch. And this difference creates a transmural repolarization gradient that is responsible for the J-point elevation. So then what about the basis of ST elevation? The loss of the action potential dome in the epicardium results in abbreviation of the action potential as seen, while this does not happen in the endocardium, and the resultant transmural gradient between the endo and epicardium results in ST elevation. Now, coming to a newer pathogenic concept of Brugada syndrome. Now, what would be termed as the current load mismatch. Now, there is a significant current to load mismatch in the subepicardium. The reduction in the sodium current, which is due to the channel dysfunction, was found to cause failure of subepicardial excitation. And this is related to the current to load mismatch. And this results in a structural EP relationship and resulting in ventricular arrhythmias. So the current to load mismatch, which is worse or which is more prominent at discontinuities, can result in conduction block and right bundle branch block. So the newer pathogenetic concept is on the current load mismatch. So what are the recommendations for diagnosis? It is recommended that Brugada syndrome is diagnosed in a patient with no heart disease and a spontaneous type 1 Brugada ECG. It's also recommended that it is diagnosed in patients with no heart disease, but who have survived a cardiac arrest due to VF or polymorphic VT and exhibits a type 1 Brugada, or it can be induced by sodium calcium channel blocker challenge or during fever. That is important. Now, there is a Shanghai score, which is based on ECG findings, clinical history, family history, and genetic testing. And it is definite if it is more than 3.5, possible in 2 to 3, and non-diagnostic in 2. Now, look at the genetic testing. The pathogenic mutation in Brugada carries only 0.5 points. Now, this is important when you have, when you do a study or when you are not really sure about what the diagnosis is. Now, coming to the point of discussion that was been posed to me is the flecainide challenge test. The indications are type 2-3 Brugada, aborted sudden cardiac death, and unexplained syncope. The oral dose is, you need to be careful about the oral dose. In adults, you can go up to 200 to 400 milligrams. If you are a little worried, you can use 300 milligrams. ECG monitoring, 12 lead ECG, one space above right-sided leads, and take ECG for every 5 minutes for first 30 minutes and every 30 minutes for 3 to 6 hours or till the abnormalities revert. And what is this pathophysiology of sodium channel blocker? Now, the main determinant, as we said about the type 1 EKG, is a significant conduction delay in the RVOT with reduced RVOT conduction reserve. And the sodium channel blockers of flecainide increases this conduction delay and also increases the area with conduction delay to result in type 1 ECG. In fact, when you do an EP or when you do a ablation, if you give flecainide, you can see there is significant increase in the fragmented QRS. So this was the data from Chitra. The response to flecainide challenge test was about 50%, and it was done in about 56% in type 2 and 3 patterns. And the time to positivity on oral flecainide ranges from anywhere from 1 to 3 hours. Now, coming to VT induction, is there a role for VT induction and EP study? It is certainly controversial, but it has been a standard protocol in Chitra. We would do a triple extra from the RV apex. Now, what is the rationale? Rationale is that 28% of EP positive patients developed VF, while only 2% who were negative. Basically, indicating the role of a negative predictive value. Now, in Brugada, in Brugada et al., who had published that EPS is an independent predictor for arrhythmic events, while Finger and Prelude registry failed to prove the need for EPS. And on meta-analysis too, the role of EP has not been clear, and the studies have shown that it was non-significant. But one would recommend to do in our setting to see this negative predictive value. So what are the ICD indications? If you have Brugada syndrome, if it is asymptomatic, there is no role. If there is syncope, there is with spontaneous type 1, and then there is a role for ICD. But one should understand that the normal annual mortality rate of a normal middle-aged population is about 0.5 to 0.7%. And if you look at the patients who are asymptomatic, the annual mortality rate is only 0.35 to 0.8%. So the role obviously is doubtful. The recommendation for ICD implant is survivors of aborted cardiac arrest, and it may be considered with type 1 Brugada and then arrhythmic syncope. I'm just this is the last couple of slides. Now, ICD shocks. Now, in primary prophylaxis, you see the appropriate shocks only are about 5% in the data, while it is around 30% in patients who are for secondary prophylaxis. So the role is very minimal for primary prophylaxis with Brugada. And this is the data from Chitra. The primary prevention channelopathies was about 17%, but it was mainly driven by sarcoid and hypertrophic cardiomyopathy. In Brugada, it was much less. There is a significant role of quinidine. The dose is 600 milligrams. So in conclusion, the clinical syndrome is characterized by type 1 Brugada ECG. It is an oligogenic syndrome that results from multiple gene variants. The current concept is current to load mismatch in the RVOT epicardium. Plaquenine challenge test is useful to decide the significance of syncope. And VT induction carries a significant negative predictive value, but overall has only borderline significance. ICD is recommended in symptomatic Brugada, no role in asymptomatic. Quinidine is an important drug, manufactured in India, but not available in India. Thank you.
So, a very good talk. Just one question. So, if a patient comes to you and you find a Brugada type ECG, would you do anything for that patient if he's asymptomatic, or would you do anything at all?
No, if he comes with type 2-3 Brugada and if there is borderline symptoms, then one would do a challenge
Now,
test.
if a routine ECG is taken for a patient who comes to you and that shows a Brugada type 1 Brugada ECG, but the patient is otherwise asymptomatic, would you follow it up or would you just leave it?
No, we would not follow it up with an ICD, or if
Would you
that
do
is a
anything
question.
at all? Would you do
Yes,
a challenge?
correct.
Would you do a
So
EP?
if there is any borderline symptoms, one would do a EP study for a VT induction. A patient with borderline symptoms. If he is absolutely asymptomatic, there is no role to do any EP study.
So spontaneous Brugada, I mean, if there is a positive ECG, you should not do challenge if it's already showing a Brugada pattern, because there is a risk of arrhythmia when you do challenge. So only if the patient is asymptomatic and the ECG is not showing Brugada pattern or suspicious Brugada, then you do challenge.
That too in the background of history of syncope or something.
If you want to really like rule out a Brugada syndrome in asymptomatic patient, only if there
No,
is
having a normal ECG, they come with a symptom. Do you think that we should be doing a challenge test? And,
yeah, in a normal
that
patient,
or if it shows type 2 and type 3.
No, so if he comes with type 2 and 3, if he is routinely picked up, there is no role. If there is any amount of symptoms, then he should undergo a Plaquenine challenge test. But come to Madhu's question, whether if you find a type 1 Brugada is absolutely asymptomatic, follow. Yes, because it increases this sodium channel conduction problem with temperature. So it's related to fever and the temperature per se.
What is the percentage of ICD implantations, total ICD implantation, Chitra, in which Brugada is attributed as one of the reasons for ICD?
That is a fairly low number, must be around maybe 10% or so. But most of the ones with Brugada for primary prophylaxis did not have any significant amount of appropriate shocks. The exact numbers were not clearly analyzed, but we did analyze it.
No, we had only one case for the last 5 years I've taken record. We had only one case which was referred as a Brugada 1 pattern and had a syncope, but that also was not documented. We investigated, halter, nothing was shown, but then he was referred for an ICD implantation and we did it. I was not sure whether I was actually dealing with Brugada or not.
yeah, most of the syncopes in Brugada, like they are usually vasovagal. So just a syncope alone but you have to be, you have to err on the side of safety. If it looks like arrhythmic syncope, because we have patients with syncope and ICD getting recurrent shocks, appropriate shocks when they have typical spontaneous Brugada. So,
In our national channelopathy registry, we have around 40 patients enrolled with Brugada right now, out of which I think 15-20 patients had ICD also. They get actually shocks, but not as highlighted. In fact, there was a recent study in JCE article in press. I was just reading it. It's shown that patients with the Brugada, when they had undergone left bundle pacing, they done intuitively as an investigation of this thing, they have shown that actually QRS reduction happens and these patients' arrhythmic incidence comes down significantly with 18 months of follow-up. So it is still an enigma, the mechanism, whether it's a conduction delay, whether it's a primary a channel problem. People have shown an epicardial endocardial dispersion with the right coronary artery mapping and also endocardial mapping. And they have shown that there is a significant transmural delay in these patients. And some other studies have shown there is a higher degrees of T1, increased T1 value suggestive of fibrosis in the epicardial region. People have ablated from the epicardium. People have shown SCN5A mutation in the same patient. So this basically it's a heterogeneous spectrum. So everything, I mean, this is not a single disease probably.
Thank you, sir. Yeah.
1.5%. You have implanted an ICD, like sir said, we deal with these cases where they have got an ICD implanted in the Middle East or somewhere where he had a Brugada type pattern of ECG and had an unexplained syncope. You have followed him up at the time of PG change, no event in 10 years. How do you address it after that?
No, if people have looked at this particular aspect, that means whether you should actually not reimplant, but they've shown an increased, not an increased incidence, but significant incidence, so that the recommendation would be to continue with
Thank you, sir. It's been a good talk and a lot of discussion. We'll go on to the next one. Natarajan on VT Storm.
Thank you for the opportunity. Many aspects of the treatment of VT storm, some of the main aspects regarding ICD was covered elegantly by Professor Siva Prasad yesterday. And some of the aspects in the treatment of VT storm are to be spoken in the subsequent session by Dr. Anis Tajuddin. So my session will be abbreviated, hopefully. Let's see. So we will define what is VT storm. We'll go through the pathophysiology, a stepwise approach to the treatment of VT storm in terms of step number 1, immediate resuscitation. Step number 2, identification of causes, triggers, and reversible factors like electrolyte abnormalities, ischemia, so on and so forth. Of course, treatment and prevention of recurrences. In that, we correct reversible parameters like electrolyte abnormalities, we correct potassium, magnesium. Antiarrhythmic drugs, of course, have a major adjuvant role. And ICD reprogramming to reduce shocks was discussed yesterday. Neuroaxial modulation has a very important role to play because there is significant excitation of the sympathetic nervous system vis-a-vis the parasympathetic nervous system. We call it sympathetic sympathoexcitation, which can be due to increased circulating catecholamines as well as in the local sympathetic nervous system within the myocardium itself. And that gives a lot of scope for what is called neuraxial modulation. And of course, modification of substrate and elimination of triggers, about which Dr. Anis will talk subsequently. By definition, in patients without an ICD, more than or equal to 3 episodes of sustained VT or VF over a 24-hour period, or in patients with an ICD, 3 appropriate detections of ventricular arrhythmia that lead to appropriate ICD therapies in the form of either ATP or shocks. And this increases the mortality as well as morbidity. The presenting arrhythmia in electrical storm is predominantly sustained monomorphic ventricular tachycardia in about 85 to 95% of patients, and the rest is either VF or polymorphic VT or in combinations. If you go into the pathophysiology, it's very relevant to understand the pathophysiology because it has a bearing on the way we treat arrhythmic storm or approach arrhythmic storm. There is a vulnerable heart, either a structural heart disease, it may be a old myocardial infarction or arrhythmogenic cardiomyopathy or dilated cardiomyopathy, or it can be structurally normal heart but electrically abnormal like Brugada syndrome, which Professor Ajit Kumar sir pointed out in the previous session. There are inciting triggers which can be ischemia, inflammation like active sarcoidosis, for instance, electrolyte abnormalities, and increased circulating catecholamines which could incite arrhythmic storm in the background of a vulnerable heart. And of course, increased sympathetic tone, which is, when I talk about increased sympathetic tone, I'm talking about local autonomic disruption at the level of the myocardium. How do we approach to a patient who presents with a VT storm? Step number 1, immediate resuscitation. On the usual lines, we won't go into the details. We have these flow charts based on a shockable rhythm or a non-shockable rhythm, whether it is a VF or a pulseless VT versus a VT with pulse. Depending on that, we treat these patients. And yesterday there was a award session presentation on this dual sequential defibrillation that applies also to increased success rates in patients who have incessant refractory VT who don't terminate on with a single defibrillation. Step number 2, initial evaluation. The focus is to identify causes, triggers, and reversible factors, like is in this list, exhaustive list: electrolyte abnormalities, ischemia, hyperthyroidism. Very important. Patients may be on amiodarone, which can be the cause of hyperthyroidism, and that can be the reason for the VT storm. So estimating thyroid function is very, very relevant. History, 12-lead ECG at baseline during VT if possible, immediate ICD interrogation, and of course blood parameters are very important. And these are some of the typical signature patterns of electrolyte abnormalities in the ECG: hypokalemia in this instance, hypocalcemia, hyperkalemia, hypercalcemia. These all should be looked into. And also the ECG in sinus rhythm can give potential hints towards the etiology, like for example ischemia, long QT syndrome, Brugada pattern, bradycardia, which can be the reason for polymorphic ventricular tachycardia because of long QT interval in bradycardia. And also the ECG during VT helps us to characterize the VT into monomorphic or VF or polymorphic, long QT with torsades. That has a bearing on the way we treat these arrhythmias with antiarrhythmic drugs. Step number 3, the final step, treatment prevention of recurrences. Of course, all reversible parameters should be corrected. Potassium should be kept as close to 4.5 as possible, and magnesium more than 2. Temporary pacing or isoprelin in case there is bradycardia, which is the reason for the VT storm. If there is QT prolongation, stop the offending drugs. That is very, very, very important. ICD interrogation to diagnose underlying reason for the therapy by the ICD, to classify whether it is appropriate, inappropriate, or whether it can be avoided, or meaning unnecessary, non-sustained episodes, which was discussed very extensively by Dr. Shiva Prasad yesterday. We won't go into the details in the interest of time. This is an appropriate therapy for ventricular fibrillation. This is inappropriate shock due to noise, due to a lead fracture, inappropriate shock due to fast ventricular rates during AF, which match the VT detection rates. So classifying them into inappropriate and unnecessary is very important, which helps us reprogram the device to reduce the shock burden, which is very, very important in terms of quality of life as well as morbidity and mortality. And we have these criteria to distinguish these things. We won't go into the details. Antiarrhythmic drug therapy, we have these classes of drugs: beta blockers, amiodarone. Procainide unfortunately is not available in our country, and of course lidocaine, particularly in the context of ischemic subsets like old MI, so on and so forth. Propranolol is found to be superior to metoprolol in this small study, and it has a physiological basis because propranolol crosses the blood-brain barrier, unlike the more selective beta blockers. So propranolol probably is theoretically superior in the context of ventricular arrhythmia storm. Mechanism of polymorphic ventricular tachycardia. The management of polymorphic ventricular tachycardia depends on the mechanism. So it's very important to understand whether it is due to long QT. When there is QT prolongation, you call it torsades. And if it is not QT prolongation, we call it polymorphic VT as such. If there is QT prolongation, it can either be congenital or acquired. And the mechanism is early after depolarization. If it is congenital, you treat accordingly. If it is tachycardia, beta blockers. If it is bradycardia, transvenous pacing, and then give maximally tolerated beta blockers. If refractory, sympathetic denervation, and of course genotype specific treatment like mexiletine, ranolazine, long QT3. In acquired long QT syndrome, stop the offending drugs, correct electrolyte abnormalities. Isoproterenol, transvenous pacing can be done as temporarizing measures. In the absence of QT prolongation, we call it simple polymorphic ventricular tachycardia. These can be due to early coupled VPCs, which occurs in the context of channelopathies like Brugada syndrome, short QT syndrome, idiopathic VF, malignant early repolarization, and of course in the healing phase of acute myocardial infarction, triggered by the angry Purkinje fibers, which responds to isoprenaline, quinidine, hydroquinidine, and ablation. Late coupled VPCs, catecholamine mediated polymorphic VT, latent cardiomyopathies, and late coupled VF responds well to beta blockers and the conventional antiarrhythmic drugs. I want to stress the fact that quinidine is extremely useful in conditions where the polymorphic VT is triggered by early coupled ventricular premature beats. Yesterday during our Vande Bharat travel, Dr. Mugund was telling that instead of quinidine, you can give quinine in higher doses, which is currently available in India. And it's extremely tragic to know that quinidine is made in India, but it's not available for Indians. That's a little tragic. Then finally, before we close, the most important aspect is neuroaxial modulation. We'll quickly go through. I already told you there is excess circulating catecholamines, and of course there is remodeling of the stellate ganglia due to old MI-LV dysfunction and so on and so forth. So there is a role for general measures like deep sedation, intubation, paralysis, general anesthesia, mechanical ventilation. And to quieten the storm, we can give temporary measures like thoracic epidural anesthesia or percutaneous stellate ganglion block either by ultrasound guidance or by anatomic landmarks. And of course, the permanent solution will be surgical denervation. And there is also a role for renal sympathetic denervation in this context. It's for the sake of PGs, it is a fusion of the inferior cervical and the first thoracic ganglia, which is called the stellate ganglion, and T2, T3, T4. They are responsible for the cardiac autonomic innervation. So that becomes a target for epidural anesthesia, stellate ganglion block. And ropivacaine is the drug which is used, and it is extremely useful in quietening the storm in at least a large majority of patients. And surgical sympathetic denervation by video assisted thoracoscopy can be done. Renal artery denervation by denerving the renal afferent sympathetic nervous system reduces the sympathetic outflow into the stellate ganglion and thereby is potentially antiarrhythmic by quietening the sympathetic nervous system. Elimination and modification triggers will be spoken by Dr. Anis during the next session on ablation of an old MI scar, and MCS is largely irrelevant in the Indian context because of its cost concerns. However, it can be done in patients who are very hemodynamically decompensated, particularly when they are taken up for ablation, as determined by some of these scoring systems. Higher the score, these patients will benefit from a prophylactic mechanical circulatory support when you take these patients for ablation. So I'll conclude by saying that VT storm is a medical emergency. It has high morbidity and mortality. A stepwise tailored approach is very, very crucial. Reversible factors should be addressed. Immediate ICD interrogation and reprogramming can be very, very important in patients. Pharmacological suppression, depending on whether it is structural heart disease, electrical disease, monomorphic versus polymorphic, early coupled VPC should be treated differently. And neuroaxial modulation targeting the sympathetic nervous system is paramount. Catheter ablation of post-MI scar, triggers like Purkinje fibers, even VT storm in the context of Brugada syndrome can largely suppress, if not eliminate, ventricular tachycardia. Thanks for your kind attention.
Great lecture, Dr. Narayan, as usual. Now, about this neuroaxial modulation, who actually does it? You get the help of an anesthesiologist?
In our center, we take the help of the anesthesiologist. They a lot of times do it percutaneously by using anatomical landmarks. It is done at the level of the C6 vertebra. Because if you come below C6, the vertebral artery is anterior to the transverse process of C7, whereas the vertebral artery courses posterior to the transverse process of C6. So that you don't inadvertently inject the agent into the vertebral artery, which can have disastrous consequences. So C6 is the target, but ultrasound guidance is probably even more safer. And the anesthetists definitely are better than us in ultrasound guided stuff.
Thank you.
You should not do something.
Most of the difficult questions come. Maybe propranolol is the most lipophilic. It may be, that's the only way I can counter that question. Because whenever you sit in the audience, I'm very prepared to answer questions in whatever limited way possible. I kind of wriggle out without giving the real correct answer most of the time. And because of your love for your own student, you actually accept the answer. Thank you very much.
Thanks, Rajan. We'll have the last talk by Anis.
Thank you, chairpersons. Thank you, organizers. So this talk is mostly about scar mapping and ablation, scar VT ablation. It's the title tips and tricks, but it's more like a story of skills and grit because you don't want recurrence. So VT ablation, how it has evolved over the years. We've been doing this for more than a decade now. We start with reading the ECG to localize the VT, and preparing the patient is important. We have to do appropriate ICD programming before and after ablation. We have to maintain the hemodynamic status. Sometimes it requires anesthesia support and inotropes. Safe access to the left ventricle. How I do it is through femoral access, usually femoral artery access. But nowadays, when we want to do extensive mapping and ablation, we do septal puncture, at least in like 40% of the cases. Anticoagulation to maintain an ACT of around 100. Coming to the crux, the long-term success of this ablation requires thorough mapping. You have to use all the skills which are required in EP in this case, including substrate mapping, pace mapping, activation mapping, and entrainment mapping. In the earlier stages, we used to do a lot of substrate mapping, but now we are more interested in doing activation mapping to get the tachycardia during the procedure, and so that we can annotate and target the important targets for ablation. So ECG as a guide, there are various guidelines on how to use the ECG. I will not spend too much time on it. Nowadays, we also have automated site of origin localization systems. There are multiple systems available in the West where the ECG, the 12-lead ECG of the VT is combined with the patient's CT scan or MRI scan, and sometimes with the electroanatomical map, and machine learning based tools for population templates for ECG localization, which are very accurate in identifying the location. So they will map out and say to you where the exit is likely to be. Now, this is how we used to do. This is from 2012 or 13. I've been carrying these slides for so long. This is the map of with point by point mapping, how you do ablation. The advantage of point by point mapping was we get a more focused approach. We know what we are looking at, which point we are targeting. For example, here you can see there is a late potential on the left side, and you can even tag it to the unipolar electrogram recorded from the catheter tip, which means you are actually, the catheter is touching the late potential, and ablation will target and eliminate these late potentials. So we use a scar definition of 1.5 or less for scar. So you'll get a large amount of scar in this case from the anterior wall. But in these situations, you have to make an effort to make sure that you are in good contact with the myocardium, and during those times you used to depend on fluoroscopy a lot to make sure that the catheter is in contact, especially if it's a large scar. And even then at that time we had noticed that most of the interesting signals which are related to VT are located in the areas where voltage is much lower than 1.5. Like when you reduce the voltage gradient down to 0.25 or 0.3, that's where you get a lot of channels between scars, and also where various signals of interest like these low voltage potentials are located. So as you can see on the right figure, most of the ablation lesions which we have given in this case, targeting these important signals, are located in where voltage is less than 0.3 or less than 0.5 millivolt. So that's how we have learned to do ablation. Another deficit of an activation map is that when you do point by point mapping during VT, you don't get sufficient points to exactly delineate the VT circuit. But you can see an exit area which is marked red and late area which is marked blue or violet around this area. And then you have to also have the bipolar voltage map to show that you have completely covered the scar for targeting these VTs. So this is the VT circuit. I will not go into the detail because of lack of time, which was published in 1997 by Stevenson et al., and which we all use to identify the central isthmus of the circuit, because VT is now known to be produced by scar and islands of conduction tissue between scars. And always our target is to identify the central isthmus of VT, where even one or two ablations can terminate and eliminate recurrence of VT. Also, while mapping, we have to make sure that we are covering the scar entirely. And one way of doing it is that you can compare the unipolar and bipolar maps and make sure that you get a very sharp border between the scar and the normal tissue. So that way you know that you have covered the scar completely, because that's very important to prevent recurrence. So this is another substrate map, in this case of the RV, outward tract and base, in a patient with post-TOP surgery. But in this case, even with point by point mapping, you could show the activation of the VT. So in this case, the circuit is going like what was shown in atrial tachycardias. You can see the early meets late in re-entrant map. But most of the ablation points will be targeted around this area where low voltage is seen, and there is crowding of the isochrones, which is short segments with a lot of colors in between. That is where most of the slowing happens. So that is one way of doing ablation. But the emphasis is always on substrate mapping, and during substrate mapping, you have to isolate these late potentials in your map, and you have to be very watchful where your catheter is going and the signals which it is picking up. Like in this case, it is a late potential falling at the end of QRS, and you have to absolutely look at the unipolar signal. So not just the bipolar signals. Here you can see that these late potentials which are falling outside the QRS complex are fragmented, and that same signal is reflected in the unipolar catheter, which means ablation here is going to target the signal. Similarly, you can use pace mapping during tachycardia. You can pace from the RV to bring out these late potentials, which is an important target. Here also late potentials, and you can look at the unipolar signals, how it is localized at the tip of the catheter and not at any proximal electrodes. Then once we have an induced tachycardia, during our previous times when activation mapping was not always successful, used to depend on entrainment mapping a lot. So this is entrainment of VT, and this is showing concealed entrainment. You can see that the QRS during pacing, that is during tachycardia, you overdrive, and then if you are in a concealed segment within the isthmus or within the scar, you will get QRS morphology exactly matching the QRS of the tachycardia. The QRS is, the tachycardia is accelerated to the pacing rate, and there is a significant delay from the stimulus to the QRS onset, indicating that you are in one of the slow conducting zones within the circuit. And after stopping pacing, you have to look at which signal which was captured here. Here you can see that this is the small signal in the, so this is the small signal in the ablation catheter which was captured during pacing, and the stim to QRS during pacing is almost the same as electrogram to QRS during tachycardia, and this is a good site for ablation. Similarly, on the this is another tachycardia, a cycle length of 540 milliseconds, again showing that here you are capturing this small electrogram with the same post-pacing interval or slightly longer post-pacing interval compared to the tachycardia, and with the same stim to QRS. So these are points in the isthmus which are more closer towards the exit, and these may be ideal targets for ablation. So like in this figure, maybe this is located close to the exit. And then you have to look for other areas near in the adjacent area. So this is pace mapping, again showing the same QRS morphology as during tachycardia with a longer stim to QRS interval. And this is pacing during tachycardia, pacing induced VT, where there is also entrainment and showing a mid-diastolic potential during tachycardia. So I will just go through some important aspects, like you have to ideally gain up the signals to identify these very small potentials which are targets. There is multiple methods of elimination of these potentials, including elimination of the late activation potentials by pace map, decremental pacing. Scar homogenization is another technique which we don't follow exactly. Now with multipolar mapping systems, there is more confusion to us, but because a lot of signals are available, but you can get good activation maps during tachycardia. So this is a re-entrant map with HD grid. This was a recent ablation done 2 months back. And so you can see these lot of these diastolic potentials which are targets. And I also do an LAT map or activation map without putting it a re-entrant circuit with a low interpolation to show how much of the tachycardia we have covered. And so here you can see all the colors mapped out in an LAT map without using the re-entrant algorithm, which indicates that we have covered the circuit. It's early meets late around this small scar here. This is another VT which was done last month, again showing the diastolic potentials picked up by omnipolar mapping catheter, which has its own benefits. So this is the advantage of re-entry shown in activation during tachycardia. You can identify the isthmus of the tachycardia and the boundaries pretty well. So this was a patient with multiple tachycardia, I mean VT storms which are ablated with a few lesions in this isthmus region. Other lot of things to remember that about the limitations of unipolar and bipolar mapping in fractionation. So this is another new technology, the omnipolar mapping in the HD grid, which will identify orthogonal signals much better than the usual. With CARTO, it has proprietary algorithm to look at the signal in bipolar and unipolar and then tag the activity, which gives us more confidence. So there are new advancements in these various mapping systems which will help it make it better. So we also done studies with MRI integration in mapping systems. And so this is now 3D software which is available from companies which will take the MRI, integrate with the electroanatomical map, and it will even show, like in this picture, you can see the possible VT isthmuses and tracks which can be targeted, which is not yet available in India, but it can be made available at a higher cost. So now latest advancements are, creating a digital twin of your heart with the MRI and genetic information, and you can even propose various circuits which may be targeted for ablation. But in the end, effective ablation will require other apparatuses like simultaneous unipolar ablation or needle catheter in some cases, but which are not easily available for us. Finally, to conclude, what causes recurrence? Recurrence is missed targets of possible circuits. Most reablations are done within, when they are taken up for a repeat procedure, are done within 10 millimeter from the previous lesions given. So when the first procedure is done itself, if you do meticulous mapping, repeated inductions, and apply to all possible circuits, that will be the best way to prevent recurrence and to ensure long-term success. Thank you.
It's a very exhaustive talk, Dr. Anis. I just want a simple question. If a patient with a post-MI LV dysfunction comes to you, how would you say whether it's a scar-related VT or a ischemia-related VT? Would it be possible without an electrophysiological study?
So clinically, if the patient has a monomorphic VT, when the patient comes to you in a post-MI patient with scar, it is 90% of the time or 95% of the time it's a scar-related VT. Patient may have underlying ischemia as demonstrated by small rise in troponin, but if it's just a rise in troponin, it is all due to VT and not due to ischemia. But if the patient has other signs of ischemia, this is ischemia promoting the arrhythmia. So in addition to tackling the ischemia, you will have to do something for the high risk of recurrence of VT because of the scar-related tachycardia. So that is how I approach these patients.
After a VT ablation,
yeah, if there is no previous scar and if it's a polymorphic VT, the monomorphic VT nature is very important. If it's a polymorphic VT in a patient without any previous definite scars, it is due to active ischemia usually. But even sometimes, when the patient has multiple scars in the heart, it is ischemia contributing to the recurrence of VT. So that's how we approach. Yeah.
a patient with MI coming back after say 35 days or 40 days with a scar VT admitted. Now, he is being referred for an intervention and you ablated it. And do you recommend ICD along with that sitting?
Yes. So any VT after 48 hours after MI is like a secondary prophylaxis. You have to advise an ICD unless the patient has normal LV function, and if it's a limited scar where you think just ablation alone will take care of the risk of VT.
Sometimes this patient having a normal LV function came with a scar VT.
Yeah, if there is no ischemia, normal LV function, guidelines still recommend structural heart disease patients to have an ICD, but there is a role for continued medical follow-up. If the scar is well taken off by ablation, we can follow him up. I had few exposure to wearable defibrillator patients when I was abroad, but very limited experience. Generally, if the EF is low and there is a risk of VT in these patients, they all end up in ICD. Sometimes when you require time for further evaluation, then only they are on wearable defibrillators for some time. Yeah.
For example, you have to wait for 6 weeks after an MI before you consider an ICD for primary prophylaxis. That kind of a waiting period, if you don't want to take any risk, you can have this wearable defibrillator. It is available in India for rent.
Thanks, Anis. As we're running short of time,
I'm not the rent.
Thank you.
Thank you. It's a very nice and educative session. I think we'll close. Thank you. Dr. Janesh for Advanced and Cardiac MRI.
Good afternoon. My topic of presentation is advances in cardiac MRI in arrhythmia. So I'll be dealing under the following headings: the role of MR in arrhythmogenic cardiomyopathy, sarcoidosis, genetic cardiomyopathy, non-dilated LVAC, that's a new entity, it's coming in the ESA guidelines, HCM mimics, EP-MR fusion, real-time MR guided ablation, and newer MR CMR sequences. So everyone knows that this is the HRS consensus about arrhythmogenic cardiomyopathy, which has included the other sarcoidosis, myocarditis, and Chagas, which I not go into detail. So, but there's an issue with this, and the latest ESC guidelines doesn't recommend the recently used arrhythmogenic cardiomyopathy because it lacks a structural or a functional definition. So, the first heading I'll be going about arrhythmogenic cardiomyopathy, the IRVC ALVD spectrum. As we know, there's a right dominant spectrum and the left dominant spectrum and the biventricular spectrum. The right side is mainly due to the desmosomal and left side can be desmosomal plus non-desmosomal. And the right side is the ARVC spectrum. ARVC spectrum has, there is an imaging part, genetic part, and ECG part for that. And there is guidelines get updated, and we latest have the Padau's criteria where there is a role for MRA, especially in the major criteria and also the minor criteria with the dyskinesia, the volumes, and also it's in the left side pathology and also for biventricular pathology. So in the right dominant systems, we can right dominant pathology, we can have focal dyskinesias or volume or right side dilatation without left side involvement in this case. Or the issue is that these all things are just straightforward. For example, if there are 50 right dominant pathologies, the classical MR features will be seen only in 10 to 15% of cases, and ARVD itself has multiple levels. So it's a preclinical stage which can be missed. As a result, MR cannot be easy. MR can easily miss that preclinical stage and early stage. So as a result, there are newer advances like feature tracking MR for right side. Previously, it was for the left side pathologies we could do that, but the right side MR feature tracking also can help in diagnosing early ARVC pathologies. But it's very difficult because there are multiple mimics of ARVs in MRI because tethering of right ventricle to sternum, pectus excavatum, but the so-called butterfly apex, physiological fat, etc., can all mimic pathologies of ARVD, and so it's very difficult. There are multiple mimics in ARVD in MRI, and also this, which is a case of biventricular ARVC, which can be diagnosed in Padau's criteria, which has a modified or a displaced triangular dysplasia in the left side involvement also, which shows an epicardial involvement of the left side and ventricular septum, which was diagnosed as a biventricular ARVC. But this case usually comes in diagnosing MR, it's slightly difficult, especially it can mimic multiple pathologies, which I'll come to later. And so there is a lot of talk about arrhythmogenic left ventricular myopathy. So is it a part of ARVD spectrum or this a separate entity? Because the latest ESC guidelines tell that it's in the spectrum of the NDVLC, and because of the different genetic mutations and non-desmosomal types of mutation associated with ALVC. So compared to the ARVC, the diagnosis of ALVC is very difficult, and even MR can also only play a small role because it can mimic multiple pathologies, especially it can mimic myocarditis and sarcoidosis. But the so-called enhancement seen in such pattern, if it is like that, there is a diffuse subepicardial involvement in MRI, at least for 2 to 3 segments, it fairly proposed that it's likely to be an ALVC spectrum, because there are some mutations that can specifically present like this enhancement, that is the enhancement of at least 3 consecutive areas with subepicardial enhancement mimics that proposed today. It's a high risk genetic variant of an ALVC. It's specifically seen some mutations, and by this we can slightly propose that it could be ALVC. And in this case, it was there was fat replacement of the interventricular septum and also the fat replacement of the lateral wall, likely due to be ALVC spectrum. And the next important thing in MR is that the prediction of genetic cardiomyopathies, and there is an entity of non-dilated left ventricular cardiomyopathy where it's in a part of ALVC or a separate spectrum. It's not clearly understood, but in the latest guidelines, it's written that if there is it's a non-dilated left ventricular cardiomyopathy which has normal ejection fraction, it is an arrhythmogenic potential, and some genes which are high-risk genes can predispose these patients to arrhythmic potential, and these patients are a class 1A recommendation for ICD. And there are some specific mutations, so high-risk genotypes, especially these 6 genes mutations are written, which has high predisposition to sudden cardiac death. And some of this genetic mutation can be identified in MR, especially the lamin mutation, the the DSP mutation, and PLN mutation can have some specific signatures in MRI. For example, the ring-like enhancement, the late Gardner enhancement can return to late specific enhancement of the lamin mutation, which has a very poor prognostic indicator. So also in DCM spectrum, especially we know that 30% is genetic, and there is a matrix criteria for ruling in a genetic and dilated cardiomyopathy. There are multiple genes implicated, and MR can help in multiple patterns. For example, it can diagnose a secondary DCM, and also in primary DCM, it can quantify the scar, which is a prognostic marker. For example, 30% of the patients can have mid-myocardial scar, which is a poor prognosis. In addition to that, it can also propose multiple secondary genetic cardiomyopathies, especially the lamin mutation. For in this case, there was a diagnosed lamin mutation, which shows subepicardial enhancement for long segment. So it's suggestive lamin mutation. And also in this case, there is an atrial standstill. This is an emeroid reflex dystrophy with associated spinal muscle, fatty replacement of the paraspinal muscle. This is also proven for lamin mutation. And this was a retrospective proven case of titinopathy, where there was a patient present weakness, and there was a dilated cardiomyopathy, which doesn't show an enhancement. So this, because we know that the titin spectrum has a lesser, it has a better prognosis compared to the lamin spectrum, which has a poor prognosis. So it can prognosticate with cardiac MRI. The second part is cardiac sarcoidosis. Cardiac sarcoidosis can be the active stage and inactive stage, and MR can show the active stage and also the fibroid stage. But it is less compared to the PET scan, because the PET will show the degree of activity. It can be used for the follow-up. But the scar quantification, that is a major adverse cardiac events, can be predicted by the by MRI. And another issue with the PET is that you must be on the PET, that specific diet, sarco diet, which is slightly cumbersome. Patients should be on that diet for at least 2 to 3 days to offload the heart from glycogen's metabolism to fatty metabolism. But there are some specific markers in cardiac sarcoidosis, because it can mimic myocarditis or IRVC. The so-called hug sign or a corner sign, where there is involvement of the endoventricular septum to the right ventricle involvement, is slightly specific for sarcoidosis, can rule out other diseases. And this was in cases where there is systemic sarcoidosis, like in this case, where there is involvement of the brain. The diagnosis in the cardiac diagnosis is slightly straightforward, and you can see the granuloma in the heart. It can diagnose sarcoidosis. Or there is a lung involvement in this case, where the infiltration of the lung, you can diagnose sarcoidosis with this classical involvement of the basal part and with aneurysms. But it is slightly difficult for there is an isolated cardiac involvement, because it can mimic myocarditis, ALVC spectrum. The role in HCM, it's straightforward, because everyone knows the role of in MR and HCM. Is it can show that type of enhancement, and there is a scoring ESC guideline scoring system and a newer AHS scoring, where in the intermediate risk you can take the consideration of the scar quantification in HCM cases to place an ICD. And also there are poor prognostic factors like apical aneurysms and extended scar for HCMs. You can also quantify the scar, which is a prognostic marker in HCM. And there are multiple HCM mimics. The so-called HCM, which doesn't have an HOCM, can have other mimics like Danon's disease, Fabry's, PRKG mutations, etc. And MR has some signatures in some diseases, especially in case of Danon's disease, where there is scar of the lateral wall with sparing of the endoventricular septum. And pre-excitations, PRKG mutations also can have specific signature markers in MRI. In this case, it was a PRKG mutation was diagnosed. And also with the so-called hot HOCM, with hot HCM, which extensive scar with normal LV ejection fraction, it's likely there are new articles coming like this, likely due mutations of LK3 mutations. So it can also prognosticate and also find out other rare causes of hypertrophic cardiomyopathy phenotypes, and also mitochondrial myopathy in this case. The next role is for fusion imaging. As previous speakers told, MR can be used as a guidance of MR itself can be used for fusion imaging, especially for deep scars and epicardial scars, and also in cases where the anatomy is slightly difficult. But the problem is that it's like slightly lower spatial resolution compared to CT and other techniques. And also MR can be used in atrial fibrillation cases, post-fibrillation, we look for the pulmonary isolation gaps. But this is the EAC study, and this is the MR map, which shows better PIV gap, pulmonary isolation gaps. Similar studies can be also done in ventricular tachycardias and to bring out post-ischemic cardiac myopathies. And also, you can do the fusion for CT, MR, and fusion of CT plus MRI in mapping. And so the CT brings the better spatial resolution, MR brings out the better contrast resolution. The latest kit in the tool is the advanced real-time MR guided electrophysiology, where there is no need for that EP lab is the MR. And so in the MR itself, we can do guidance. The catheter tip will be gadolinium based tip. So you can push the gadolinium tip catheter in the MR, and there is no need for fluoroscopy. So you can do the pre-contrast MRI, do the access, do the tracking of the catheter in the MR guidance. This is the catheter tracking, and you can ablate the lesion and do the post-contrast imaging in that time itself, look for the response. So it's especially for transmural lesions and patients with complex congenital heart disease, where the anatomy is slightly difficult. The last part is regarding the measurement of cardiac dysynchrony. So there are new sequences for MR, like a dense sequence, which is like almost like a straining imaging counterpart of the ultrasound, but it's slightly mathematically robust and in such a way that it can do complex calculation in MATLAB to synchronize these all bits so that we can get what is the proposed ejection fraction improvement after a CRT. So it will just take the peaks to a single peak and using MATLAB, and you can calculate how much ejection fraction can improve after a CRT placement. And also regarding the issues regarding the in MRI issues with MRI, there is a sequence called wideband LG where it can bring down artifacts very less because it has RF pulse is wideband, and as a result, it will bring down the artifacts. So to conclude, the role of CMR is increasing. It can help in narrow the differentials, especially, and identify the high-risk markers in genetic cardiomyopathy. There is a role in HCM mimics, and it may help in some mid-myocardial epicardial scar localization, and it may be a future in real-time MR guidance ablation. And there are new sequences for implants and prediction of CRT response. Thank you. Yeah, we can differentiate. So tuberculosis, by the spectrum itself, tuberculosis usually have a pericardial involvement. There will be pericardial involvement. Sarcoidosis is unlikely pericardial involvement. Then the T2 weighted images, the sarcoidosis granulomas won't be that much T2 hypoindents. Tuberculous granulomas will be severely T2 hypoindents granulomas. So by the myocardial involvement, we can differentiate. It's mainly pericardial involvement. Myocardial involvement also we can differentiate. Third thing is that involvement area. So subepicardial involvement and basal involvement is likely towards the sarcoid etiology. Tuberculosis can have varied pathology, but it's morely sarcoid will have a basal involvement with subepicardial involvement of the lateral. Fabris is you can take a T1 mapping. So T1 mapping, if you take for Fabris, it will be severely reduced because of the lipid content. But it can pseudo-normalize in the late phase. It can pseudo-normalize and become T1 normal. And there will be, at the time of pseudo-normalization, the lateral wall will show scars. That it's an HCM mimic. So it will mimic an HCM. We cannot diagnose him.
One more.
Sir, I have one query. So nowadays we are saying that MR gives us a kind of a characterization that normally histology will give. So
it will never.
No, my point is, see, in many cases of DCM, where you have a fibrosis, but which is a kind of uniform pattern of fibrosis, where you are not able to get a null point. So, having no LG, will we be able to say like it's very benign?
So, fibrosis is classically described as interstitial fibrosis and replacement fibrosis. So, there is an interstitial fibrosis, LG, the so-called light guidance enhancement, won't show any enhancement. For such cases, there is a diffuse involvement. It's a mapping. There is a parametric MR imaging, T1 mapping. It may show a decreased value, a high value. So, increase in value in a parametric mapping itself is a poor prognosis sign because the interstitial fibrosis has started.
Yeah, that's my point. So most of the times we don't do this parametric, we don't do those kind of studies. We entirely focus on LG. So that is something. So
LG is a better prognostic marker compared to the parametric prognostic marking LG is better because it's already replacement fibrosis happen. Interstitial fibrosis is an early sign only. So if there is a replacement fibrosis happening, it's a poor prognostic marker.
With that, we'll conclude the session. We had excellent 4 speakers. We congratulate all of them, and we'll go to the next session.
Due to shortage of time, we'll not be breaking for lunch. Moving on to the next session, chasing the circuit. For chairing the session, I invite Dr. Abhilash SP, Dr. Ajit Tachal, and Dr. Praveen G. Pai.
I think as we are running short of time, this is a case-based presentation. I will first call Dr. Arun Gopi for his presentation.
Respected Chair, friends, I think most of the things about substrate mapping and VT ablation has been discussed in the previous scenario. So in people with VT in structurally abnormal heart, one arena which you would need to dwell into is pericardial space in some rare scenarios. So these are the situations where you think of an epicardial axis. That is when the ECG suggests epicardial VT. That's primarily when you have in the VT delta like in the beginning part of VT, which is called pseudo delta of more than 34 milliseconds. If the QRS is really broad, you have a slurred upstroke of the QRS in the VT. You have an intrinsic reflection time more than 85 milliseconds. These criteria are well described. The shortest RS of more than 121 milliseconds and the overall QRS duration more than 211 milliseconds. These are all criteria which suggest there could be an epicardial VT. Primarily, there would be absence of Q waves in the inferior leads and presence of Q wave in lead 1. So if on ECG you think of this, prepare yourself for an epicardial axis. Other indications are when there's an unsuccessful endocardial ablation done earlier. If your MR imaging, as earlier described in the previous talk, if it shows a subepicardial scar, and when you're dealing with substrates like ARVC, sarcoidosis, HCM, ischemic cardiomyopathy in 16% of cases, sometimes the substrate is all purely epicardial. So this is the two needle we use for the epicardial axis, and the subsaphoid approach is taken. Typical approach is to have a contrast injected, find this stenting and then go through. Nowadays we are avoiding this because there's always the contrast staining. So here you can see we are not injecting, we are just actually puncturing and then tracking the wire up, and then typically we use the axis is actually get understood with the give way feel of the needle. We wire and ensure that you are in the pericardial space, and then always take this epicardial agilis. This actually gives a lot of leverage in movement in the epicardial space. You can see with the epicardial agilis and the flexibility catheter, you can go around this point in multiple ways. And our conventional protocol is always to have mapping. During the mapping time, we use a 2 ml irrigation, and during ablation, 17 ml per minute irrigation. Aspiration of fluid during the procedure of ablation, continuous hemodynamic monitoring, put a pigtail at the end of procedure, remove the pigtail if there is no hemopericardium at the end of 24 hours, and intrapericardial methylprednisolone 125 at the end of procedure, oral steroids and antibiotics for 5 days. I'll come to the cases. First case is an ischemic cardiomyopathy, underwent an ICD implant, post-ICD implant, recurrent VT shocks, recurrent ICD shocks, underwent an endocardial ablation in 2022 March. 1 year down the lane, he was asymptomatic. Subsequently, again started to have repeated episodes of ICD therapy. So this is a recurrence of VT after an endocardial ablation, and so we were prepared for an epicardial axis upfront. So this is the ICD log showing numerous therapies delivered, and so we upfront go with an epicardial axis. So and then we do a substrate mapping in these scenarios. So this is an epicardial signals from the HD grid, and this is a contact force enabled tacticath ablation. Actually, you can find that we go behind the fragmented signals and the late potentials. This is the ILAM map showing the deceleration zone. We correlate the deceleration zone with the scar border zones on the voltage map, and then do a substrate modification or a scar homogenization in the areas of interest. So it's more like a substrate-based map, a substrate-based ablation here. In this case, where this person had recurred after an endocardial ablation for a scar VT with recurrent ICD shocks, now an epicardial axis taken and pure epicardial substrate modification done with a contact force catheter. Now 1 year after the post-epicardial ablation, he's had no events for the last 1 year of follow-up. Second case is a person with a hypertrophic cardiomyopathy with an apical aneurysm, underwent an ICD implant in 2019, now came with recurrent ICD shocks. It was substrate of HCM with an apical aneurysm. So we were thinking there would be a substrate in the epicardium as well. So plan was to have an epi-endo activation mapping. This is the ICD log showing numerous episodes of therapy over time. And this is the clinical VT. These are the kind of VT where you think of epicardial access. Actually, you see the slurred up stroke. You see a negative Q in lead 1, positive QRS in 2, 3, and AVF. So these are typical VT morphologies, and you see the slow up stroke and wide QRS, where you think of epicardial access up front. A patient was brought to lab in VT. We actually map the endocardium first. We find an early area in the anterolateral area, but in the early area, you find that there is nothing, no activity in the diastole. You're finding an early activity, but nothing in the diastole. We do an entrainment mapping. There's concealed entrainment with the stim to QRS being almost equivalent to EGM to QRS, and PPM anesthesia is 0. So this probably was the exit site. We went ahead and ablated the exit site. You can see that the VT terminates at the end of ablation of endocardial VT terminates, but then still it was reinducible. So we were thinking probably the isthmus is probably mid-myocardial or epicardial. So we went, so in this case, we take the epicardial axis, we go in the, just in the epicardial location of the site where we ablated, but we find nothing interesting in the epicardium there. And both on ILAM and voltage map, we find nothing. So we come back on the endocardium and give consolidation burns. So it was probably a mid-myocardial substrate. We ablated the exit in the endocardium, and that was done. And this patient is doing so far good. The final case is a young male, a dilated cardiomyopathy, normal coronaries, had an endocardial RF ablation about 10 years back, now came with a VT storm. He's had a family history of sudden cardiac death, normal coronaries, cardiac MRI clearly shows a subepicardial scar. So upfront the plan was an endo-epi mapping. So, and this is the ICD log. You can see numerous shocks, very frequent shocks. Most of the VTs that are converting with even a 7-joule shock. And this was a clinical VT, again, pseudo delta and Q in lead 1, again, making us think in terms of an epicardial VT. I'll just take this one more minute actually. So most of the VT had a trigger PVC to begin with. So we first go behind this trigger PVC. The first one is a trigger PVC, and there are multifocal other PVCs as well. So we find that the earliest activation of trigger PVC is on the anterolateral wall. So we map first the trigger PVC and do a pace map at this side. This is a pace map for the trigger PVC showing 12 by 12 match, and we find that it's about, there's a pre-potential there about 18 milliseconds earlier. We go ahead and target this trigger PVC. Subsequently, there was one more PVC from the anterolateral papillary muscle that was also ablated, and subsequent induction again shows a monomorphic VT induced. We go ahead and map the epicardium. There are a lot of, we again do a voltage map and a substrate based ablation. We find a lot of interesting signals which are shown earlier. This is the late potential there. This is the fragmented potential there. We go ahead and do the ILAM map as well as the voltage map, correlate that and find the interesting signals, do a scar homogenization on the epicardium. So you can see actually these are the late potentials which are melting on ablation, and purely it's a substrate based ablation on the epicardium, but this did the job for him in his 3 months post RFA, no episodes after that. So whenever you're into the epicardial space, two things to be taken care of is ensure that you're away from the coronary, you're away from the phrenic, and watch out for pneumopericardium, pericarditis, and to conclude, basically sometimes a combined endoepicardial approach is complementary to fully treat the arrhythmic substrate. It is usually safely performed with us but ensure that you have a surgical backup, because sometimes you can have unpredictable bleeding complications. It's all about pre-procedural planning. Understand whenever you need to take an epicardial access, it's always better to have upfront epicardial access based on your 12-lead ECG clues, your failed endocardial ablation, even an endocardial unipolar voltage can tell you whether it's an epicardial scar or not. And sometimes MRI in these cases tell us upfront wherever you want to go with an epicardial axis up front. So before I conclude, I thank my team for the help and the support that Shabri gave us in mapping of these complex cases. So thank you.
Thank you, Aaron. Just a question about the first two cases. In the first case, that epicardial late potential didn't seem very late. It was just after the QRS. So, did you do any pacing to see if you could induce any delay?
We paced from the ICD lead itself, and it was further delaying out on the pacing, and that actually made it more manifest actually.
Okay. So that was not there, but you did pace, and you made it later. And the second case, the QRS morphology clearly was very suggestive of epicardial. So did you consider mapping the epicardium before actually ablating the endocardium?
No, actually, we were so much tempted that we found it early, what concealed, and when
that
we
was an
knew
exit.
that it was epicardial, we ablated endocardially. It was still inducible, and when we went epicardial, it was still there. But then, while we were mapping, we couldn't have a sustained VT in the epicardium to map it. But there was Surprisingly, no interesting much areas in the epicardium. Although ECG wise typically look epicardium, probably we proceed.
I'm just wondering whether the initial endocardial ablation affected it in some way. What were your?
It could be possible. It could be very well possible. Yeah.
Great cases, Arun. In the first case, after the first endocardial failure, did you do a hybrid or only the epicardium?
No, next time only epicardium.
Why didn't you do an endocardium? You were.
So endocardial, we had already done a substrate modification done, and he was symptom free all the time actually.
Okay. And the ECG was it suggestive of epicardial?
No. This time it was purely recurrent ICD shocks. We just did an epicardial and still no episodes.
Any role of imaging you do before you?
Yeah, the last case was very clear because on the MRI itself there were subepicardial scars.
In the first two cases, it was not done.
No, it was not done. They already had. It's really tough to ablate mid-myocardial. People have done bipolar, people have done needle-based ablation, but most of the time mid-myocardial substrates are quite tough to take care of. Yeah, we are actually finally ablating the exit, but we are not very sure it can exit in another way. So mid-myocardium is always a difficult scenario. That's what earlier all these newer advances are in targeting this mid-myocardial area. They have a needle-based catheter for ablation. They have bipolar ablation and a lot more of things in that.
I think in the interest of time, we will close. Great cases, Arun. I will call the next speaker, Dr. Richard Raj. See, the time for presentation is 6 minutes and 2 minutes for discussion. Okay.
Good afternoon, everyone. I thank Dr. N. sir, Abhilash sir, and Jodhivji sir for giving me this opportunity. With no further delay, we'll go into the case in detail. So my patient happens to be a 49-year-old homemaker from Sri Lanka. In 2017, she presented with complaints of function class 2 dyspnea on exertion, which worsened to function class 3. Later, she was diagnosed to have an hypertrophic obstructive cardiomyopathy with a severe LV outflow tract obstruction and a moderate MR. So she underwent a septal resection with an attempted mitral valve ring annuloplasty. But on table, there was residual moderate to severe MR. So we had to go ahead with the mitral valve replacement. All these things were done in Sri Lanka. But immediate post-op, she developed atrial fibrillation with a fast ventricular rate. There was no ECG documentation of which, but however, rate control and anticoagulation was started. And in spite of all these treatments, she continued to have worsening palpitations. The beta blockers and other rate controls could not be elevated further in view of significant rate-related symptoms. So she underwent a permanent pacemaker insertion with Medtronic pacemaker in October 2023, after which the symptoms continued to be persistent. So she came here for further management. ECG shows baseline sinus rhythm with an LVV morphology. And this was a wide complex tachycardia that was documented with the same morphology and the axis as the baseline rhythm, and rate around 150 per minute, likely to be a flutter with a 2:1 conduction. Echo also shows there is no significant LVOTO and there is no significant prosthetic valve dysfunction, and the LA size of 37 mm. So we went ahead with the EP study based on cycle length of 862 milliseconds, AH interval of 128 and HV of 56. And during the EP study, tachycardia was induced spontaneously, and the tachycardia cycle length amounting to be 322 milliseconds. And you could see that the activation pattern is also from 910, the coronary sinus to 1-2 from RA. And during the EP study, as it continued, the tachycardia cycle length from 320, it changed to 268 with a change in the pattern of activation as well. And 1-2 was activated much earlier than 910. So there was another circuit in addition to the RA. So we first had to exclude the RA. So we did an entrainment from the CS ostium, which showed a post-pacing interval of 380, which was much longer than the tachycardia cycle length, excluding it from the part of the circuit. So we went ahead with the voltage mapping. Voltage mapping showed the gray least voltage region, the connection between the right upper pulmonary vein and the mitral valve annulus. This is a region known as a Waterston groove, which is the incision where the surgeons make to access into the LA. And this was confirmed by the activation mapping as well, where you can see that this is the isochronic crowding area here, in and around the same region. So we also excluded that LA is not, roof is not part of the circuit, since the post-pacing interval is also much longer than the tachycardia cycle length. and the ablation was started in the isthmus region. And here you can see that the 2-3 AVF, initially the positive P waves turning into be negative, and in AVL, the negative P waves changing into positive. So there was successful ablation going on the isthmus region, after which the activation pattern still continued to change. The one more tachycardia cycle length of 330 milliseconds, which was much longer than the 260 which was in the LA region, was seen, and the pattern was from 910 to 12. So there was another shift into the RA. So we had to find out the exact location. So entrainment was done in the RA appendage. RA appendage showed that the post-spacing interval was 368, which was longer than the tachycardia cycle length, excluding it from the part of the circuit. However, the high lateral RA with a post-spacing length of almost similar to the tachycardia cycle length, as well as the CTI region, were both found to be included in the part of the circuit. Voltage activation mapping also confirmed that there was a counterclockwise pattern of in and around the CTI region. So that was ablated successfully. And during the ablation, post successful ablation, the sinus cycle length has improved back to 856. And to confirm the bidirectional blockade, we had to perform the medial to lateral conduction time, which was 164, as well as the lateral to medial conduction time, which was 168. So bidirectional block was confirmed, and this was the final ECG with the sinus rhythm as well as A-paced rhythm intermittent with baseline LVP morphology. After the procedure, patient is doing well right now on anticoagulation. There is no beta blocker therapy, there is no rate control. She is asymptomatic right now, and she is on regular follow-up. Thank you.
Thank you for the presentation. I didn't understand how the title correlates. I think your title said two circuits for one. So
yes, sir. There are two circuits for the same patient. That's
okay, that's what you meant. I thought you were talking. Okay, the two different. Okay, coming to the presentation, what was the voltage definition you used when you to depict a scar during the activation map?
So 25 watt.
No. The voltage definition, because there was a lot of gray. The problem with these bad substrates is if you put your low voltage ID to a largish number, 0.2 or something, you get a lot of gray area. So what number did you use and why? That will really define your 3D map, that number that you use.
That was exactly not sure, sir.
Okay, that's it.
Did you try to do any AF atrial fibrillation induction during the procedure?
No,
because patient had earlier AF, no?
No, sir.
Patient did not have any recurrence after.
After the 2017, there was no documentation of AF, and we didn't induce it, sir.
Okay. Thank you. Any question, Abra? Okay. Thank you. Good presentation. We'll call the next speaker.
Next presenter is Dr. Yogesh Kulkarni. Mystery of Equidistant Sites is the title.
So first, thank you to organizers to give me this opportunity. Directly, I will come to my case, mystery of equidistant site. So this is a story of a 18-year female who came to us with a complaints of recurrent palpitation since 1 month, and she has a structurally normal heart. So this is a baseline ECG which is showing sinus rhythm, and there is no any pre-excitation in this ECG. And this is her tachycardia ECG, which is showing a narrow complex tachycardia, but the P wave morphology was not clearly visible here. So we directly go for a Holter to get more information about the mechanism of the tachycardia. So you can see here the 3 strips of the Holter, and the first strip, upper strip, is for the sinus rhythm, and the middle strip was showing actually the initiation of the tachycardia. In the middle of the this strip, the tachycardia started. And the important thing is the first P wave of the initiation of the tachycardia is similar to the all other tachycardia P waves, and the third strip was showing the termination, and it is terminated with a QRS. And the next strip was showing the tachycardia is going on, the P waves are coming regularly, and suddenly a QRS is dropped, most probably due to AV block. It is showing that the tachycardia is continued with AV block also. So from this we get an information that there is no PR prolongation is required for the tachycardia initiation. Initiating P wave is same as the tachycardia P wave. tachycardia is terminating with a QRS and A is more than V sometimes during the tachycardia. So from that we came to the conclusion that it is an atrial tachycardia and we went forward for the EP study and ablation. So this is the during EP study tachycardia induced spontaneously. Then we compared the sinus P wave with the tachycardia P wave. The P wave was positive in V1, so most probably we got a clue that it is coming from the left side, and as well as in the inferior leads, and the lead 1 was all negative, so it is showing from some inferior and the lateral part of the LA. So then this is the spontaneous initiation of the tachycardia. Again, the CS12 was earlier showing eccentric activation. This is also showing the left and the lateral part of the LA, which is causing this activation. Then we compared the CS12 EGM with the P wave, and the CS12 EGM was around 21 millisecond ahead of the sinus of the tachycardia P wave. Then we started mapping. Initially, we started mapping in the LIPV region, we thought, which is the most probable site. And in the LIPV region, we got that the LIPV signal was almost on time with the CS12 signal. So then again, we started mapping in that region. We came to left atrial appendage region. Here also, we got a slight earlier signal, 24 millisecond ahead of the P wave. As we are getting slight early signal than CS12, we given an ablation lesion here, but tachycardia didn't terminate, it continued. So we again mapped in the similar region, but the EGM was not that great early, around 24 millisecond was earlier. So then what we do is we do an ablation, another ablation catheter in the CS, and again mapped in the distal CS, and here also we got around 24 millisecond ahead of the tachycardia P wave, and here also again we are given an ablation lesion, but that is also not successful. As multiple lesions are not successful, we plan to do a 3D mapping for this thing, and this was the 3D map what we got. So what we here is seeing a large area which is showing earliest activation, and then where we have mapped actually the left atrial appendage, LIPV and distal CS, they were showing similarly early signals. Now what we got information from this is the LIPV, LA appendage and distal CS have similar early signals, which are 21 to 24 millisecond earlier. So we thought that all these sites are actually equidistant from the actual source of tachycardia, and most probably that was epicardial. Now this site is like posterior, inferior, lateral and posterior part of the mitral isthmus, and in the ridge of the left, at the left lateral ridge region, and the vein of Marshall is actually this is the site of the vein of Marshall, and vein of Marshall is a proven site for atrial arrhythmias. So then what we done is we put a Agilis sheath inside the CS, and our ablation, irrigated ablation catheter as much as distal possible into the CS, and there we got a very good signal of 37 millisecond ahead, which was the best signal we got up till now. And then we are given an ablation lesion here, and within 2.7 seconds the tachycardia terminated. Then we removed our ablation catheter, put a JR catheter there where we have given ablation lesion, and do a contrast injection, and we can see a small streak of contrast going upside, which is the vein of Marshall. So after that we have done a Holter. There is no any tachycardia after that, which was previously very much incessant before ablation. So from the take home message is that the Holter is the initiation termination of the tachycardia, gives very pivotal information for the SVT. During mapping, if there are multiple sites are early, then the focus is equidistant from those early sites, and vein of Marshall is often a forgotten trigger for AT and AF. Thank you.
Thanks. This is a good case, but it's a lot of retrospective learning. It's like that you ablate and then you figure out that this is where I should not have ablated. Yeah. Is there a couple of things you could have done to predict before ablation that this is where I should ablate or should not ablate?
Actually, initially we didn't. Vein of Marshall also previously they told.
No, I'm not talking about the vein of Marshall. I'll be more specific with my question. Why did you choose to ablate at the site which was 24 milliseconds early in bipolar without looking at the unipolar and without entraining to find out if it's focal or reentrant? That's actually the question I wanted to ask you, but I just...
Because this, we thought this is the, on the basis of P wave morphology, we got this is the...
No, the only, you found a bipolar site 24 milliseconds earlier than the P wave.
Yes.
Why did you think that this is the site of origin of tachycardia?
Initially, we didn't thought about vein of Marshall. So just we...
No, we are not talking about the vein of Marshall. All I'm trying, don't take it in a bad way. All I'm saying is, no, don't take just that one point to decide that this is the source of tachycardia, because you got it was a near field bipolar. Because you got a near field bipolar 24 milliseconds early, I'm sure you must have figured out it's a focal tachycardia by the activation sequence, even without the entrainment. So just because you got a near field bipolar 24 milliseconds early, don't assume that this is where I have to burn. The least you should do is look at the unipolar, and 24 is, well, not good enough. Now, if you had to go by early bipolar only, which you shouldn't, you should at least, hit some 30, 35, 40, but you should also look at focal. Unipolar to decide if that's a focus.
Yes.
Yeah, same thing. I think wherever you showed that 24 milliseconds, so you didn't show that that is the earliest. You showed that it is only early, that's all. And there are no other unipolar signal as he has told. And if you are suspecting vein of Marshall, you should have done the CS angiogram before itself.